Welcome. Today, we have an opportunity to have a very interesting conversation with one of the more innovative care delivery groups in the United States. We're going to be talking with Dr. Chris Chen. Chris is a fully board certified cardiologist, but for the last 12 years, he's been the CEO of ChenMed. Chris, ChenMed is not a typical medical group at all. Can you tell us a little bit about ChenMed and describe kind of a sense of its scale and breadth?
Yeah, absolutely. ChenMed, actually was started by my dad over 30 years ago. He had this very unique practice. And even in those days, he noticed that there was, two major fundamental problems within healthcare. There's a cost problem. Everybody talks about the cost of healthcare. We've been hearing about it for decades, right? But in reality, the cost problem is not across the entire population. In any given cohort of people, you roughly have about 5% of a population that accounts for 45 to 50% of the medical costs. About 15% of a population accounts for 75 to 80% of the med costs. So really what you have is a med cost problem driven by the grand minority of the population. So that's problem number one. Small group of people are spending the majority of the costs. The second thing that he noticed is that there are massive disparities with how healthcare is delivered and the subsequent outcomes that come from that variability of how healthcare is delivered in all the zip codes in America. If you the most recent data from the Robert Wood Johnson Foundation, we're in New Orleans, and there's a zip code in which the average life expectancy in New Orleans proper is 57 years old, the life expectancy. 57 years old. Just 3 miles away, you have in the same city, in New Orleans proper, a zip code in which the average life expectancy is 83. That's a 26-year difference. You do the same thing in Chicago, that number is close to 30-year difference. And so, this is really, in this country, at least to my dad, and now in this country, is a major problem of social injustice. So you have the combination of those two things coming together. You have, substantial interest and costs being driven by a minority of the population. You have massive, social inequities in terms and healthcare outcomes. And so my dad said, hey, there's actually an intersection of how those two come together. Let's figure out if we can create a model. Let's go into some of the most underserved communities and see if we can fundamentally change the cost curve, number one, and number two, substantially improve the outcomes of these underserved populations. So what he created was the ChenMed model. And let me describe to you what the clinical model is. What we discovered is that healthcare today is outrageously reactive. If you're in the Medicare world, there's something called ABD. A is how much you spend on hospitals. Hospitals are the grand majority, the largest cost in healthcare today, followed then by Part B, which is mostly specialty fees. A large portion of that Part B, by the way, is also spent in hospitals during an acute visit. And then there's Part D, which is drugs. And so if you look at the inpatient volume and the inpatient costs from acute visits, plus the let's call it the professional fees spent during that acute admission, plus all of what my dad would call the fruit from that tree, all the post-acute work, the rehab, the multiple visits, the lack of coordination, the readmissions, all that stuff. You're talking about that is actually the majority of the cost of healthcare. And so the theory was, I wonder if we could spend a little bit more upfront and substantially bring down catastrophic acute admissions. And if you could create that environment, everybody wins. So here's the ChenMed model. The typical PCP takes care of about 2,300 patients under their panel. That's why when you go to your PCP, everybody's rushed, right? Because they're always in a rush because there's 2,299 other patients waiting for them. In the neighborhoods that my dad was looking at, that PCP to patient ratio is over 3,001. We said, why don't we go to those neighborhoods? Let's search out the oldest, the poorest, and the sickest. All the poor and the sick. So this is that high-risk population that actually, costs the most in healthcare. And can we deliver them a better than concierge medicine, level of service and prevention? So our ratio is 400 to 1. Concierge medicine is typically 600 to 1. So you went from 3,000 to 1, concierge would be 600 to 1, and we're delivering 400 to 1. And the theory is if we could take that 400 to 1 ratio, give that amazing PCP a team that's trained, amazing technology that actually helps them manage their population through, not just in EMR, but also complex analytics. Could you substantially reduce the hospitalization rates? We provide our patients with transportation, door-to-doctor transportation. We provide them with on-site specialists. We provide them with on-site pharmacy services. And that cohesive, holistic approach towards prevention and towards managing the patient is what we deliver at a 4:1 ratio to that old, poor, sick population.
So it's this conference is all about value-based care, Chris, and what you're describing is a classic value-based care model. Move upstream, manage the primary care perfectly so that you dramatically reduce specialty use rates and hospitalization rates. I understand too, you insist on capitation.
That's right.
Mostly Medicare Advantage populations, the sickest of the sick is where you target, and you insist on capitation. Tell me something about that, this capitated payment model. Why?
So this is really critical. But the hypothesis is if we can provide this concierge medicine on steroids, which is outrageously expensive, can we reduce hospitalization rates by 30 to 50%? Because if you can reduce hospitalization rates by 30 to 50%, the money that you save from reducing that hospitalization rate by 30 to 50% goes and invests in prevention and has enough to grow. That was a hypothesis. And so we actually published the data pretty early on, I think it was 2013, that we can reduce hospitalization rates by 38%. We then take that same cohort of people some years later and said, now the number is up to 50%. And we can substantially reduce it. We've taken that model and we've replicated it now in 24 cities. And all of those cities are following the exact same trajectory in our ability to reduce hospitalization rates by 30 to 50%. And so it creates this virtuous cycle. Now, in order to reduce hospitalization rates, here's the problem. We as doctors are not trained to do that. We have almost no training in how to prevent catastrophic events. I'll give you an example.
Just react to the current acute problem, is what you're saying, yeah.
This should shock you. So actually, it won't shock you, but it will shock you. So I finished, I did my training at Beth Israel in Boston. So, the house of God, everybody talks about that. And then went over to, New York Presbyterian at the, Cornell to do my cardiac training. I think it's the first CCU in the country, right? Talk about reactive, but great training. I had, was board in internal medicine and then 4 cardiovascular, specialties. So the equivalent of 5 board certifications. So came home to practice with my dad. And he says, Chris, I need you to help me figure out how to prevent problems. So what is the number one problem of cardiac problem? And I said, oh, everybody knows it's coronary disease and heart failure and all those things. Chris, let me ask you a question. What percent of, do you think heart failure or heart disease in this country, which is the number one cost in this country, the number one mission, what percent of it do you think is amenable to or due to lifestyles and behaviors? And, I think about other countries like Japan and certain places in Asia, and I think about, no, probably between 80 and 90% of heart disease is because of our lifestyles and behaviors. So Chris, that has nothing to do with clinical care. I go, no, probably 80 to 90. And if you go talk to, other colleagues or in the cardiovascular, industry, they would say, yeah, probably if you eat great, you live right, you exercise, you don't smoke, you do all the right things, you limit your stress, you sleep well, you know what? You can reduce your cardiovascular risk substantially. Then he asked me, Chris, how many classes in lifestyles and behaviors did you take through your fancy schooling, the fanciest schooling you can imagine that's offered in the world today? How many classes did you take? I said, 0. Not even a 30-minute class during this entire journey. So what he's saying is, Chris, so much of being able to prevent catastrophic events is actually not just clinical care. In order to invest in a patient to prevent all these horrible catastrophic events, you actually need the entire capitated dollar. You can't have just a typical, 4 or 5%, 10% of the premium to go and try to figure out how to manage a patient. You need more dollars and you need the freedom to use those dollars. So we cannot take fee-for-service. We only do global full risk. We want the entire premium dollar. So what does that look like? COVID hits. Okay. So of course we're pretty nervous about it. and it was coming to get us and our patients, and we were so nervous about it for our patients. And so we said, we need to help them immediately. So while everybody else was trying to figure out how to get funding for telehealth, we went from 95% in-person visits to 100% virtual visits in 1 week. Before anybody was even lobbying for payment for telehealth, we went 100%. We started having love calls. We were calling our patients love calls. We were calling them literally once or twice a week to make sure that they weren't anxious. We were going to the supermarkets to pick up toilet paper for them, so they weren't out there running around, trying to get toilet paper like everybody else. And we were delivering it to their home so they could stay happy, healthy, and at home, and miss at least that first wave. We needed that flexibility. You can't have that in a fee-for-service environment. It's just not possible.
You're describing patient-centered care in spades. I mean, it all makes a huge amount of sense. I can see how it works. So high-risk populations, Medicare Advantage, but the freedom given by full capitation where you own that life and you can put patients at the center of your care. Now here's a funny thing, Chris. I work with a lot of systems around the country, and so many CEOs tell me, oh yeah, we really want to do this. We really want to get into value-based care, but we can't find an insurer who'll play ball with us. The insurers just aren't willing to play with us. Has that been your experience?
So we obviously have a pretty broad experience with payers. We work with them very closely in all the cities that we're in. And as I mentioned, I think now we're in 24 cities. There's a pretty unanimous goal for every one of them to drive as much value-based care as possible. And they're looking for as many groups like ours. When we first demonstrated that this type of model could exist outside of Southern California, Southern Texas, and Southern Florida, those were the original sort of hotspots that sort of created these models. And most people didn't think it was possible outside those three areas. And so we were the first to start de novo and show everybody that it could scale. And we demonstrated that around 2010, 2011. And when that happened, there was a huge slew of what people would call Me Too Chen meds, some of which have gone public and are thriving today. And they're doing a great job. Okay. And every time I talk to plans, they always look at me and they go, how do we have more of you guys? And I said, well, first of all, venture capital is investing billions of dollars, for people to grow more Me Too Chen meds because they've seen what the public market is demanding and what people are demanding. So people are going out there and trying to create their own version of what I just described for you, and it's beautiful. But you're saying, but what about systems? All of those entrepreneurs are rising up to create these things because systems don't want to do them. They don't. They don't want to do them. It's not because the plans don't want them to do it. It's because the systems either aren't capable or aren't interested in transforming their care model. Why? Now, why would a system who owns all of healthcare? Because now in this country, we either have a monopoly or a duopoly in every single geography in America today.
That's right.
So if you're a monopoly and you control prices, you control volume because you also have all the primary care doctors, or the majority of them. And you are the number one voting entity or number two voting entity in every single market. Why would you transform? Tell me what, transformation is painful, I had there's a business, author named John Maxwell. I was on the phone with him recently. And he said, Chris, I've discovered that everything that you need for growth and development is outside your comfort zone. And everything that is good is uphill, and everything that you don't need is downhill. And I said, wow, that's pretty simple. So what incentive, if you own the entire market, what's your incentive for going uphill and doing the hard work? You don't have that incentive. And so
you don't have a financial incentive. How about a professional incentive that it's the right thing to do for people's lives? I mean, there is that incentive.
No, absolutely. So keep in mind, I always preach that these large systems are like the most amazing people stuck in a broken system. Yeah. But here's the problem. We have a system that is perfected to increase volume, right? That wins financially. when more people are sick. I had an executive once join me. He said, Chris, I left, I joined you. I said, why are you here? He said, because my CEO for a children's hospital called me up at the top floor and we all celebrated. I said, why'd you celebrate? He goes, because our ICU and burn unit was full. And so you're like, so you're crying at the same point you're financially celebrating. So we have this massive perverse problem here. And what do you do? And these are beautiful people. I was recently, had COVID, almost died from COVID. I was in the ICU, and the most beautiful people came in to keep me alive. Mm-hmm. And I said, my goodness, these are the kind of people that are working in these hospitals, but the system is so flawed. And so the system is driving people towards that high acuity, that volume business constantly. And then actually there's no incentive to drive towards prevention. And so here's the biggest, so if I find it very rare that a system would go to a health plan and say, I want to do risk, or I want to do capitation. And the health plan says, no, thank you. I can't imagine that happening. Now, I can't imagine a situation where a health plan says, okay, tell me about your commitment to risk. Tell me about that. Because here's the problem. In the past, a health plan said, I'll help you drive risk. I'll drive even more volume and more patients to your centers. But unfortunately, what a lot of these plans have seen in the past is, are you familiar with fake it till you make it?
Yeah.
What these plans have seen is you fake it, you act like you do want to do value-based care, you consolidate all the patients. So you fake it until you have enough market power to raise prices and control volume. Right. And that's what they've seen. So they said, tell me how much are you willing to invest in transforming your care model? And plans know this. Schizophrenic healthcare doesn't work. You cannot have a doctor go into one room, use one EMR system that is perfected and designed to increase volume and billable procedures and downstream, revenue. So I'm a doctor. I go into a room. I said, okay, are you a fee-for-service patient? You are a fee-for-service patient. Beautiful. I need to write a 5-page note so I can bill at the highest possible amount. I know that there's big MRI machines, specialists all over the place that I'm going to feed in mass. And all of these other things, I'm going to spend as little time as possible because I need to see 25 patients that day. I need to have these huge panel sizes, so I need to spend as little time as possible. I'm not interested in the outcome because I'm not paid for the outcome, I'm paid for the visit. I need to write a long note and I need to pump it downstream. Now, hold on, wait. Oh, I got another room. This is Mrs. Smith. Mrs. Smith is very complicated. I can't spend my usual 10 to 15 minutes with her. For this patient, I'm actually in bed with her outcomes. Because if she gets admitted, that's on me. And I'm going to be held accountable for the outcome. So I'm going to spend more time with this patient. I'm going to get to know her family. I'm going to look at her other social determinants of health. I'm going to get to know if she's safe at home. I'm going to look at her diet. I'm going to look at the exercise. I'm going to go much deeper and take a much more holistic approach. I'll go to her house. I'm going to go and, I'm going to make sure she's taking her pills, not just like, here's a prescription, go fill it. It's your problem. And then I'm not going to send her to the specialist. I'm going to make the specialist come here so that way I can talk to the specialist about her because I don't want her to get lost with a lack of coordination here, which happens in healthcare. Okay. And then I have a completely different piece of technology and analytics and data that does exactly the opposite of what this piece of technology does. That's not compatible. Those two things in the same doctor, that's not compatible. There are two different philosophies of care. And so trying to do both at the same time is a recipe for failure. And there's no true willingness to drive that. And so what ends up happening with these health plans is they go, I'm sorry, what you're going to do is I'm going to send you all our patients. You're really not going to transform your care model. And then when you have enough patients, you're just going to raise prices on me and tell me, too bad, who else are you going to go to? So that unfortunately is what we're seeing in all the 24 markets that we're in today. And there are some beautiful examples, though, of systems that are trying.
Yeah, so Chris, I have to say two things about this. The first thing I have to say is, as a physician, as a nurse, as a clinician, we have a deep dedication to our patients, and that model too, Mrs. Smith, that's how most of us want to practice. We want to take care of those individuals. We know them as human beings. We want to help. So it's a model that appeals to our shared professional values. The second is this: I have an old friend, or had an old friend. He was a professor at Harvard Business School. His name was Clay Christensen. We were actually many, many years ago as young men missionaries together in Korea for the LDS Church, is where we first got to know each other. But Clay developed this idea called disruptive innovation. I think you're a classic example of a disruptive innovation. You're picking up the patients that in some sense nobody else wanted, the complex, the hard, the difficult. Then you're moving into those markets, picking up the people no one else wanted, and you're really making it work, and then you're growing up through the market. Yeah, I think that this is just a classic example. If Clay was still alive, he would be all over it. He would love it deeply. But you know, relative to that, how's it working out? Is GenMed growing? What's your future as a system? What do you see as the future of healthcare from a GenMed viewpoint?
So, you know, the most important part of our organization are the clinicians. They actually deliver the outcome, right?
Yeah.
And I love what you just said. You said, you know, this as a doctor, this is exactly what I wanted to do. You know, when doctors join us, or they're looking at us, we said we will allow you to practice medicine the way you thought you were going to practice, but never were able to. And you realize that I don't ever have to explain what that is. Every doctor has an idea of what they thought they were going to do. And then they came out and they go, oh, this is what healthcare is. And so there's a massive shortage of primary care doctors. And you're saying, Chris, how do you grow with a massive shortage? And doctors are burning out left and right. You're hearing all about it. And then we tell them, well, you know, we actually don't have a doctor shortage problem here. Why? We tell a doctor, you don't take care of 3,000 patients, 2,300 patients, take care of 400, take them really, really well. You're going to be held accountable for results. So we only are looking for the best doctors who can actually deliver great results, build a great team, and we actually give them the team. So they have to run a great team and utilize all the, you know, the great analytics and technology that we have. And they can be outrageously successful, more successful than their peers in a fee-for-service environment. And they are recognized for it amongst their peers for delivering better results. They can actually prove it. And so we have about 3 applications for every 1 doctor that we take. As a result, you know, we are a private organization, so we've been very disciplined. We haven't done anything crazy, but we typically try to grow at a CAGR of about 30 to 40% annually. We've been doing that for almost a decade. Actually, just over a decade.
That means you're 40% bigger every year, is what you're saying. Every year you're 40%.
30 to 40% bigger every year. Yeah, every year.
But I think you're beating that actually.
Well, you know, in different years it changes, and you know, it's you know, there's different demand in different years, and but yeah, 30 to 40% in, you know, CAGR. Some of my other, like we call them Me Too GenMeds, some of them are growing at, you know, 40+% per year, and it can be done. But there's just tremendous demand. Just imagine if you're a patient, what would you like to be? Would you like to be 1 out of 2,300 or 1 out of 3,000, or would you rather, you know, have your doctor's cell phone number? You know, have a doctor that if anything happens to you, you have to. I know that doctor is going to be held accountable by their peers. Every time there's a bad outcome, that primary care doctor presents that case to their peers. This is what you want for your mom, right? And so there's huge patient demand. Our net promoter scores are through the roof, like never seen before in healthcare. And so the patients are winning. The payers love it. The payers love it. Payers have, you know, they get a really hard rap because they're trying to lower the cost of healthcare. But the way they've been doing it is by trying to lower price. So they get, you know, they go to these systems, or they go to doctors and say, hey, you know, you charge, you know, $100. I need you to do it for 80. Systems say, or doctors say, no, I'm not going to charge you 100. I'm going to charge you 300. Why? Because I'm bigger now. So, and then it's a price war. But this is a model that has nothing to do with price. What we do is, because we are fundamentally improving the health of the patient, the acuity level goes down. And so there aren't these acute admissions. Like, you know, as a doctor, you show up in the emergency room. This patient shows up every month. Why? Because he keeps eating Chinese food. That Chinese food meal that led to that admission is $15,000. Yeah. It's not a $30 meal. It's a $15,000 meal. So what could I do with $15,000 to try to prevent that patient from coming back every month with heart failure? And so that you can imagine there being tremendous demand for something like that. And so, I came out of the hospital with COVID, which the ability to experience care on the opposite side in an ICU bed was just priceless. And the ability to really think about purpose and, what your life is about is just priceless. And I had this beautiful privilege to do that, not knowing which way I was going to go. But, praise God, happy to be alive today. But, came out of the hospital and my phone started ringing. And I said, wow, this is interesting. And I said, these are all people probably checking up on me. And some of them were. And some of them were calling me to say congratulations. And I was thinking, congratulations for what? For surviving? Yes, I really appreciate that. No, it turns out that at Fortune magazine, they have this list where they say, these are the group of companies that we think will change the world. I think there's like 53, 54 of them. 30 of those companies out of the 53 or 54 were in the United States. I believe 6 of them were in healthcare, and there was only one healthcare provider, and we were that one healthcare provider. It was such a humbling moment there. I go to my my executive team and the people in the company, and I tell them every day, I said, what a privilege it is to be able to transform care in America. Yeah. And now I got someone from the outside telling us, no, Chris, you and your company, your sights are set a little bit too low. The expectations for, and I've never been told that before. And so I said, oh my goodness, maybe this is a model that doesn't just work for the US, but actually can work beyond. And, the Lord Darzi from the UK, when he came and visited, wrote an article about it in the Guardian. And maybe he was onto something, that this is the way that healthcare is supposed to be practiced, where everyone wins.
I have some people that I really want to introduce you to, Chris, in a couple of other countries where I'm doing some work here, spot on. I think what we've just seen, though, is the future of care delivery. I really do. It's based on that value-based care model where you move upstream, reduce downstream expense, better patient outcomes, dramatically lower costs. I think we're seeing the future, and you're just a walking example of it. So thanks for sharing. Thanks for sharing your vision. Thanks for sharing your challenges and successes. Thanks for sharing the future. Any last words from your standpoint, anything that we've missed that you really need to say to this group?
I do. The majority of healthcare today is still in fee-for-service. And they're still driving volume, and they're still, financially celebrating high levels of acuity and events that we should be able to prevent. What's stopping people from making that transition, from continuing healthcare in a direction that we know leads to worse outcomes, and making the jump to saying, this is proven now. It's not theoretical anymore. You actually need to stop the placebo arm. The clinical trial is done. The data is out there. Have the courage to go jump into what you know now works. And it's not going to be easy. Delivering better outcomes is far more difficult than just driving volume. It's far more difficult, but it's worth it. Yeah. And so, having purpose in your career and making a difference, that's got to mean something. And for those of you who are really like thinking to yourself, I got a short life, whatever it is, 40, 60, 80, 100 years. I want what I do to matter, to make a difference. Then you need courage to do that. So I'd like to inspire you to have courage, those of you who are out there, and hopefully you can help make a difference.
Thank you, Dr. Chen. It's been a delightful conversation. Thanks for sharing that vision and sharing that future.
Thank you so much for having me.